It's great to finally meet you because this is how we meet each other nowadays through Zoom. So why don't you tell us a little about yourself and your organization and what you're passionate about?
Great. Well, thanks, Chris, for inviting me to talk with you today about innovation. So I have an organization called BrightSide Solutions, and we're really focused on putting strategy back into health plan portfolio design and delivery. Such a highly regulated environment that it's become almost a maintenance function and not a strategic function, right? So my background is I've been doing this for many decades. I have what I call a policy heart, but an operations brain. So I've studied policy at some of the highest levels, but also worked kind of within the belly of the beast at various health plans and other organizations that cover California Exchange. So I really like taking those the policy ideas and trying to implement them and innovate within the space to say we should be and could be keeping people alive longer, helping them live more quality lives, giving them a better experience with their high cost item that they have to purchase.
Mm-hmm.
Yeah.
So things are not very good right now. Were things ever really good in that space, or have we seen like a sea change at some point in recent history?
Despite our efforts at a big sea change, I think the biggest sea change we've seen is in coverage. So we are down to about 8% uninsured across the country as a whole. Some areas are much bigger, double-digit uninsured. Those are largely states where they did not take advantage of Medicaid expansion during the ACA implementation. And then some of them are lower, like California has a much lower, probably 3-4% maybe uninsured. So from a coverage perspective, more people have coverage. However, that coverage is becoming increasingly expensive, and in some cases, completely unaffordable to use. If you have coverage and your deductible is $5,000, it's really a $5,000 credit that's, unsecured debt that someone can happen into by no fault of their own, or they'll just not to go and it's sicker, or they'll show up in an emergency room and that ends up costing us more. So, the places where we haven't seen a sea change are in the cost and quality of care. And I remember sitting in the early 2000s in a meeting with a Kaiser chief medical officer when I was at the Pacific, which is now the Purchaser Business Group on Health. And we all, very eager, policy-minded, wanting to make big change on the behalf of large jumbo employers, Boeing, Walmart, really big employers, thinking let's coalesce our purchasing power and see if we can make some big changes in the market. And everybody just, wholeheartely agreeing, lots of shaking heads around the table at this presentation around how unsustainable the pace of healthcare cost was. And, 23 years later, we have not only managed to sustain it, it's become even more unaffordable.
So, what happened at that time? Why did it not work? I mean, like you said, everyone was in violent agreement. Why didn't it move forward? What was stopping it?
Yeah, and I think that what's important for the audience, I think that you cater to this, startups and innovators and kind of futurists, is to understand that standard economic market principles don't really apply in healthcare. And there's so much written about this. There's a ton of reasons why, and these aren't just my ideas. These are, big ideas that have been published. But we have a very fragmented and disorganized system. Let's talk about one obvious situation. I am purchasing on behalf of somebody else who is a user. The employer and I'm the buyer. My money is going to the carrier directly. So who is the carrier's client? I, the employee, am the user, but I'm not actually paying for that service. And so there was a lot of hope when the ACA came out that there would be these individual plans and a bunch of people would have individual coverage and that could help shape markets. And in some ways it has, but in some ways it hasn't. So then we have the issue of the distribution of membership across multiple different carriers in a lot of states, not all. Some of them are just owned by a Blues plan, multiple different purchasers. And so there's no national coalescing around the systemic change that has to happen.
Mm-hmm.
If we're going to really make change, you can't go to a provider system and say, for this 1% of your membership, we want you to do things this way.
Right.
And for the other 2%, we want you to do
What's
them.
in it for them, right? I mean, that's how they're looking at it.
Yeah, and they've got, millions of members or hundreds of thousands. I come from California, so I always think of millions, but, may have hundreds of thousands of people that they have to work with every day. And you want me to do something different by the person, but to the person, to me, is going to go through my system, right? Here's the order of operations. Here's how we do things.
Mm-hmm.
And so to get to that seat change that you're asking about is going to take some very coordinated efforts across public and private sector purchasers who have very different customers that they serve, and those customers have different needs. And so it's difficult to do that without, quite frankly, some regulation and legislation.
Was there ever a time in the past where things were a lot better and we sort of veered away from that, or is it's just become more complicated?
Not since I've been doing this. I don't think things are better, but it depends on who you ask.
Mm-hmm.
So for consumers, there was a large dissatisfaction with HMO, right? So consumers hated HMOs. They hated the gatekeeping model. It really was an experiment that was intended to be good, but in actuality resulted in a lot of adverse effects.
Mm-hmm.
Providers took
What was it about the HMO model that didn't work?
So, HMOs are built on this idea of risk and population risk. And this isn't operational risk we're talking about. This is actuarial population risk. And so if you agree that for every member, you're going to take X amount of dollars per month, and for that, you're going to manage their care, you really have to know what you're doing. Right. And so initially we had providers and some health insurers who didn't understand how to manage, from an actuarial perspective, population risk. Mm-hmm. And they took on too much and they went under. And we saw a lot of that in the 90s, late 80s, early 90s. So there was a lot of shrinkage. I think we used to have something like 25 plans in California.
Oh, wow. And now we have not hardly any.
Hardly any, right?
Yeah.
So if you think of Pacific Care, Health Plan of the Redwoods, Lifeguard, or what they were called, there was just a bunch of them.
Yeah, and the smaller plans were probably catered to different individuals, right? So everyone's got their own. I mean, more choice is probably always better, right?
Right, but this shifting of risk, which is the right way to think about it, and that was kind of early pay for value. Mm-hmm. I'm going to pay you to manage the health of the population. So people are getting sicker on your dime. You're going to lose money. And unfortunately, carriers and provider systems who are receiving this capitation, many of them lost so much money that they had to go into, bankruptcy and shut down. And so then the state, created an agency called the Department of Managed Healthcare of California to help regulate and take over the fiduciary oversight to make sure that carriers have enough money, carriers and anybody who has a license to hold risk, that they can reserve enough dollars to pay for their claims run out. So blah, blah, blah. You get really technical. So what
that's fine. I mean, I don't really understand how it works. I mean, other than I understand how insurance works.
Yeah, no. So that was the kind of early days of this idea of value-based purchasing. So before that, consumers had indemnity plans. This is our parents, right? Mm-hmm. Our parents had these indemnity plans, and for that you went to the doctor and they covered so much dollars, and the rest of it was on you. Mm-hmm. Moved into insurance. And so, or what some people would say is not really insurance, which is really coverage. So our current insurance models, the ones that we're frustrated with as policy folks, are these fee-for-service PPOs. 70% of the people in the United States are covered under a PPO. And a PPO is just quite simply, you go to the doctor, the insurance carrier pays your doctor X amount of dollars that the doctor has agreed to for that. And if it's an in-network provider, you don't pay anything after that, or you pay a cost share. It could be $10 or it could be 10%, which is trickier because you don't even know the cost of the visit you're going to have. So what's 10%? Who knows? find out later. Good luck with that. And then there are limits, you have out-of-pocket maximums, et cetera. But there's nothing that says in that PPO model that providers should coordinate care with each other, that your doctor should talk to your cardiologist and should know if you hit the emergency room the weekend before. There's no incentive for any of that coordination of care. There's no incentive for quality. So if you are a really good cardiologist and the guy down the street is not a great cardiologist, you get paid the same. There's no benefit to that. There's definitely no public reporting, so you aren't going to know. So there's a lot of still a lot of flaws, but from consumer perspectives, they like the idea of choice, or they think they like the idea of choice. They on an individual level through surveys, we hear all the time, I myself am happy with my healthcare situation. I also think the healthcare system is broken, but don't change my situation.
So, but the brokenness is, I hear from other people, I'm okay, but everybody else is not okay.
Don't change mine. Here's my situation. And I think, Chris,
we've gotten used to mediocrity. That's basically it, right?
Oh my God, the bar is so low. And I think if you are in a group of family and friends, if you ask to a person, have you had a bad experience with healthcare systems in the United States? Everyone's got a story.
Oh yeah.
Everyone. And oftentimes they're tragic. I mean, it's really sad. So we pay almost twice as much as other countries, other developed nations, for the cost of healthcare, and our life expectancy, infant mortality rates, they're all very low. So we're not getting the bang for our buck.
Right.
And it's so fragmented and disorganized that a consumer really doesn't know. Is this a doctor? I don't know. See, affiliated with a good system, that's a good place to start. But really, you know more about your dishwasher than you do about the guy or the gal that's going to cut into your heart valve.
Yeah, that's about right. But I'm originally from Canada, and I have a lot of Canadian relatives, and they also have a story about their system. So it sounds like no one's really figured it out, like what actually works for anybody. I mean, there must be some systems in the world that are manageable cost wise and actually provide good care.
Absolutely. And you can find those data are readily available around, what's working well in Germany or Australia, the UK, NHS. And so, people do have stories. I think what's sad is that here in the United States, we're paying so much money to get so little. And when we talk about how little we're getting, we're talking about actual lives.
Yeah. So, I don't understand why this is such a hard problem, other than there's so much money sloshing around and everybody wants a piece of it. I mean, don't people want to improve
how
people's health?
I mean, we can get very provocative here if you want. I mean, so
no, I mean, what's the point? The point of it is to improve people's lives, improve people's health, right? And whether it's that's being proactive or reactive or whatever, it just seems like that doesn't seem to be the direction that we're going. It's like they're not interested.
Well, is that the goal? Or is the goal to feed your own business model?
Right.
In a business model, we're a capitalist country. So, this is, even in a nonprofit perspective, this is for-profit medicine.
Right.
So we can talk about some of the largest not-for-profit systems that are bringing in $20 billion a year in annual revenue.
Wow.
That's a machine. It needs to be fed. And it's I hate to be pessimistic, but I think in order to really find an opportunity for large scale change, it's hard for me to believe it won't be regulatory. Because if you look at the market, the attempts, the graveyard of attempts, they've been made by very big organizations with really smart people and a lot of money. So Google, Apple, Haven, which was, Berkshire Hathaway, that whole,
I keep hearing about these initiatives, but then nothing ever seems to come out of them.
No, they're all gone. They've all sunset, and so when I talk with innovators, when I have clients that are looking to innovate, I say, one of the values of having somebody like me on your team is that I know that where the bodies are buried.
Mm-hmm.
I can tell you which, what we've tested, what's worked, what hasn't worked. Price transparency is a great example. We used to think, well, we'll publish prices. We'll
Mm-hmm.
let everybody know how much it costs to go to hospital A versus hospital B. And that had two effects. This is what we know. If you publish prices without quality indicators, two things happen. Consumers associate high cost with better quality.
Mm-hmm.
So they start going to the high cost provider
Yep.
because there's no other information that they have. And then the lower paid providers want to make more. They're like, wait a minute, why am I not making that much? So that bombed, right? So it's important to understand that, we have piloted innovation for decades and we know the results. And if you're an entrant in this market and you think you've thought of something that nobody else has, you're most likely wrong, unless it's, on AI, machine learning. There's a lot of opportunity in that. But if you have another product that you're thinking, I know what we need to do, check the research. And then the other problem with the innovation is just getting the adoption and scale and really understanding how complex the systems are. So if you want to make even a really well-intended health system, health insurer that really wants to do the right thing, the cost of trying to make the systemic change because of the complicated nature of the entire marketplace is overwhelming.
Mm-hmm.
There may not be, if you're talking about a 5-year return on investment in managing someone's
good luck. No one can even think that far out. Are you kidding?
Consumers move plans and they, with labor mobility now and people moving all over the place, we're not staying at organizations for 20, 30 years anymore. Millennial generations, Gen Z, they think they're stale if they've been there for 3 years. They're ready.
Oh yeah, 2 years is the average, I think, nowadays. It's basically.
So I'm going to invest in your health. That's a 5-year plan. So who's in the best place to do that? Providers who might have you for a long time. Now, if that provider's capitated for you for a long time, there's some incentive there. Government, if I'm on Medicaid or in Medicare, certainly. And so you see a lot more innovation really out of some of the government programs and CMS and their innovation center than you do in the private sector. Shoot, I don't think I answered your question with how to solve the problem. Darn it.
Well, here's one thing I noticed. So, like I said, I'm here from Canada. I've been here for 20 years or so. The first thing I noticed is that your healthcare is attached to your employer. And I thought, that's kind of weird. What if you're changing employers all the time? Does that mean you have to change plans? And I thought this is like the dumbest model, especially now when we have all this mobility where people are switching employers all the time. It's like, why can't the plan go with the patient or the individual? It just seems like such a backwards way of doing things. I don't know. How did that come about? Who came up with that? Is it employers just saying, hey, my workers are unhealthy, I need to help them? Where did that come from?
Well, it kind of started with plans like Kaiser, which really was their shipyards or their businesses. And they had, Kaiser's happy to tell you all about their history on this one.
I'm going to check their website.
Yeah, this is their claim, is that their workers were getting tetanus from rusted needles. So they started, hiring nurses and doctors to help treat their folks and just try to be proactive, and hence born this
interesting
Kaiser model. Yeah, and I think what is more fascinating to me, and certainly I can send you some information about other reasons why we have this employer-based model, which is unique in many ways. If I make steel, managing healthcare is not, it's not part of my strategy.
No, it's not part of my core business at all.
It's not part of my core business, and not something I'm good at.
It's a cost center. It's a
cost center. So there was a brief window of opportunity as we were architecting the ACA, Obamacare, if you prefer, where we could have done similar to what South Africa did. So when South Africa went from went into an individual model of individual coverage, like what we did with the ACA, their employer model completely shifted. Almost everybody went over to the individual model. But it was fascinating to watch. And this is a lesson in behavioral economics, right? And change, resistance to change.
Mm-hmm.
There was a whole lack of willingness and push from lobbyists to have certain tax protections in that law to keep employers able to still, offer their coverage. I mean, it really was one of those moments where you think rational minds will prevail. Let's develop.
Wait a minute, you're talking about humans and rationality at the same time,
and healthcare, which is like triple threat.
Yeah,
so
exactly.
But let's if employers want to participate, to find contribution, give me some money, let me go and purchase what I need on the market, because employers have to limit the types of plans that you're offered. I mean, it really doesn't make sense. And I think that I love the book Predictably Irrational, and I think it's so important from a behavioral economic perspective in healthcare to understand human behavior and resistance to change, whether it's telling somebody, smoking is going to kill you, but people still smoke. Obesity will kill you, but people still are unhealthy. Like we see all these instances where people are making irrational decisions because the rational decision is better for them.
Yeah.
So when it comes to healthcare, I think, culture eats strategy for lunch. And, I had so much hope for so many years in that we would see some big sea change. And we actually had a health plan called Sea Change. I don't know if you remember that.
Really?
Yeah, there was a health plan called Sea Change. They went under.
Oh no.
It's almost impossible to start, something new like that. But again, it was a very rational approach to some of the market problems. But unless you have that stakeholder and market power dynamic solved, you're not likely to make it happen. And unless somebody is making it happen. So whether it's again, all the large purchasers, not just 20 of them, but all the large purchasers get together and say, we demand quality care from our health insurance plans. Nothing's going to happen. You have to demand it. Or the government says, every health plan has to have a certain amount of their revenue, and it has to be big enough that paying it out isn't just the only option. It has to have a certain amount of the revenue at risk unless people are getting healthier.
So what happened in South Africa? Are they still on that plan? Is it working well? What?
Yeah, and employers will supplement with supplementary benefits, but most of the people purchase it from the marketplace. And I think there's health care, there's health insurance, there's what should be core. We have what we call our 10 essential health benefits in the United States. Maybe there's a split in the market around what is funded, as I don't want to say regulation, but something where, this is never for profit. Your actual health is never for profit, but cosmetic surgeries,
there's a core set of services that fit into that.
Right. Certain elective surgeries, certainly if you want to go pay for that yourself, you should, or you could, or, whatever you do. So there's, I think, a lot of different ways that we could mix it up to say, to make people, to treat diabetes better, because we do a terrible job here.
Oh yeah.
It's awful. It's just awful. We're going to have to put pressure somehow on a market that has sustained itself for decades on, as you said, mediocrity or worse, and double-digit rate increases, decade after decade.
So I've always thought that one of the reasons why socialized medicine might work in other countries is because of the size, right? You've got Germany, you've got Australia, you've got Canada. We're talking less than 100 million people, 80 million people in Germany. I mean, we're huge. I mean, would it work here? Because maybe the scale is a problem. I don't know. I mean,
I think the scale is definitely a problem. I think you're right. I think the bigger problem is that we're trying to change something that's already been in place for so long.
Right.
So, but if we would start out brand new, would we have created employer-based market space, I don't think so.
Hmm.
So the bigger, and you could, oh gosh, it's so fascinating, Chris, honestly. Again, back to the ACA, we saw some really fascinating behavior that we didn't expect. So we
Hmm.
politicize this so much that you can't just say, I am in favor of better quality and lower cost. People will all of a sudden, you're a liberal or you're a fascist or whatever it is, they just take this, you have
This is an apolitical statement you just made. It has nothing to do with politics.
and it's so political. So, when they architected the ACA, which came out of oh my God, this think tank out of Boston, conservative think tank out of Boston. It's not a liberal policy. God, all of a sudden the name of the think tank is escaping me. But in any
Hmm.
case, these were, Romney put this in place in Massachusetts. This is not a liberal
Right.
model.
Yeah.
And the government, when they passed it, they thought, this is great. We'll offer all the states incentives to adopt this program, and we'll offer them Medicaid expansion, so they they can cover more people, more sick
Yeah.
people,
Sounds like
more.
a win-win.
Oh, just for sure, because there was all this money involved. And what actually happened, which is fascinating to me, is states said no. And this is why the implementation was so effed up, is because there
Uh,
was this, bailout that said, well, we'll have a government funded marketplace for any states that opt out. And there might be a few states that will opt out. So many states opted out or froze and didn't do anything. Some states took the implementation grant and then refunded it back to the government, gave the money back to the government because politically it was so unpopular. So then we were trying to set up this gigantic,
oh
national
man.
marketplace. And fortunately for California, we didn't do that. And it just, was just a big cluster. But the idea that we politicize this so much is
Mm.
really taken away from, again, the rational thinking about we want, efficiency. We want an efficient market. We want healthy people for the right cost. Not the cheapest necessarily, but definitely the right cost. And
Hmm.
right now we're paying way too much for low quality
Yeah.
as a whole, as a population.
Yeah. Well,
So
where's that money going? Like,
you,
where's the brunt of it going?
well, according to my business, it's, a lot of it's just inefficiency, and it's true.
Right.
Unfortunately, there's a lot of inefficiency. And then, it's going into shareholders.
Mm.
Just depends. We have these huge not-for-profit organizations that don't have shareholders, that are just really inefficient. A lot of money is going to specialists.
Hmm.
So, yeah, I don't want to out one of my family members, but this is making a lot of money as a specialist. Mind-boggling, and we pay so little for primary care. If you're a
Mm.
primary care doctor in the US,
Hmm.
you're probably making close to 300,000 a year. If you
Wow.
are an interventional cardiologist, your earning potential per year could be up to $1 million based on your
Wow.
orthopedic surgeons making a ton of money.
Oh yeah, I bet.
Yeah, so it's not popular to say, well, we should pay less for specialty care and more for primary care. Why'd you do that? Because primary care keeps people healthy and could keep people healthy. I will say it doesn't always. People
Hmm.
are also responsible for their own health. It's a
Yeah.
moral
And
hazard.
things happen that you have no control over.
And we're great with that. Trauma care
Yeah.
in the US is great.
Yeah.
You definitely want to be here if you're going to have a trauma. Like, that's good. But if
Exactly.
you've got a chronic illness and you want to manage it, it's,
Yeah.
you're going to go
So
to
it's almost
special.
like you have to live somewhere else and then come here for trauma care. That doesn't work.
I'm going to have my car accident in the US.
Yes. Make sure I
Yeah,
drive across the border before I get into the car
right. But I want my diabetes managed in Canada.
accident.
A lot less money.
So
Yeah.
it sounds like the only way to really affect any kind of change is from top down, right? Because although we tried, right? It sounds like we tried with the ACA and then we couldn't. Is the solution just pushing it to the states and saying, okay, state A, you can do it this way, state B, you can do it that way, and then whatever falls falls?
Yeah, I think what's going to happen is going to is that people are going to continue to argue, not implement change, keep it political.
Yeah.
There will be a point where it'll be so broken that legislation will occur.
Mm-hmm.
Is that 10 years from now, 20 years from now? I don't really know. We thought it was going to be 20 years ago. It didn't kind of happen. The ACA mostly provided coverage, and it provided affordable coverage. So if you are, and it really is meant for that working, low income worker that, whose cost of either doesn't have an offer of insurance through their employer, that still is very true for small employers, or the offer of coverage, the premium is such a big percentage, more than about 9% of their income, that they can't afford to purchase it. So, as those gaps have been closed a lot by the ACA, but it hasn't done anything to change quality.
Right.
It's provided affordable coverage to some parts of the population. So the crisis is still happening. It's just, what's the tipping point? When will it become such an economic disaster for enough people that the government steps in?
But isn't it going to be the same thing over again, politicized? Like no matter who pushes it forward, it'll be like, oh, I'm not doing that because it's you, not me. It's like, come on.
Yeah, I just think that's the question is, how much burden can we put economically in this market and continue to sustain?
Yeah.
We
Well, that's what I'm saying.
That's
what I'm saying. It might be a state thing, because you might end up not being able to do anything that makes everybody happy. Right. So you just say,
you definitely won't be able to make everybody happy.
No, we can't make anybody.
Yeah.
Not of the majority of people.
I've given up on that. Yeah. No one's gonna be happy. So I think, when you look at innovation, incremental innovation on a smaller scale within organizations, we see that happening. Things are incrementally getting better. Your experiences as consumers are getting better. Without the pandemic, we wouldn't have seen such a big uptick in telehealth. I mean, telehealth has been around for 20 years. We couldn't get anybody to adopt it. Now, this year. So, things can happen.
It's great. I love it. I love it. Yeah.
So things can happen from a policy that will open up a policy window, whether it's a pandemic or a natural disaster, something like that could happen.
Yeah.
Otherwise, I think that, the smaller scale innovation, incremental change to improvement is happening in lots of different places. The push for quality measures that are standardized is happening.
Mm-hmm.
We still don't have that. We do not have an agreement, even by state, that all the quality should be measured the same way.
Right.
And we don't have quality measures that actually are outcomes based enough. We don't have that. But
there must be a lot of pushback on quality measures, though. I can just imagine doctors saying, I don't want to be rated.
Well, here's what they say. We'll take care of it internally.
Mm-hmm.
I'm not going to tell you what my quality measures are. Trust me, I got this. I'm managing my own.
Right.
And we know that's not effective. And, a miracle would be public reporting on those quality measures.
Yeah. Yeah.
Beyond just Yelp stars or even CMS stars that, say a health plan is good at this. Again, those measures right now they're very antiquated, and they aren't focused on outcomes. They're not saying patients are better cared for, they're getting better care, they're living longer, they're living more quality of life. They're saying, did you test everybody for their A1C3?
Yeah.
Did you ask them this question? It's not really about show me that you have improved hypertension or care, and that people are living healthier and happier lives. So I think I'm done. I think I'm dancing all around your question about, what do I see happening in terms of the ways to make this big, large scale change. And I do think there are some really interesting models out there. We saw Clay Christensen's, innovation prescription, whatever it was called, but him applying his innovator's dilemma to healthcare. Again, very rational. And when that book came out, oh my gosh, it was just talk of the town. so
Hmm.
rational, made so much sense, went nowhere.
Yeah.
So we see,
I see a pattern. If something
yeah,
makes sense, it seems to go nowhere.
it's not in healthcare. So it's really about market power and how do you push change through to say, we're not going to pay for bad care.
Hmm.
So
But then you
that
don't know if it's bad care or not, right? That's the thing. It's like you need the transparency
you
to be
need the
able to determine.
transparency.
Yeah.
And then in order to have the transparency, you need the agreement on what you're going to measure. Because we're measuring that when we're measuring the heck out of providers. They're sick and tired of all the measurements. I mean, there's a ton of them.
Right.
Focus. We need to focus on some key initiatives and not over measure, but definitely not measure and do nothing with it.
Right.
That's not the answer.
What
Yeah.
about these places like Forward and other seemingly sort of like innovative things in that space?
They're
Are
neat,
they?
right? Yeah, they're
Yeah,
great.
but what are they? I mean, I'm trying to figure out. I was like, I had my wife was looking into it, and she's like, well, it's not really anything. It's like a layer on top of things, and it's not really helpful. I mean, what do you see any kind of
Well,
like
it's
something going on in that
helpful.
space?
Yeah, I mean, it's helpful because it can improve the consumer experience of the interaction with the system. So
Hmm.
I have one medical. I pay for one medical. It's like
Hmm.
$200 a year. I
Hmm.
love it. They call me back. They answer their phones. They email me right away. I mean, it's just,
Wow.
I know it's something that, have you heard of this customer service thing? I mean, it's delightful. It's such a shock. I'm like, oh my God, they really amazing.
Yeah, when you
Uh,
find that, you're like, wow.
and that's where we get into questions about equity. Doesn't everybody deserve that? Don't
Yeah.
we all deserve that? So it's not a,
Yeah, but that kind of service should be from everyone. You should
it
get
should
that
be
same kind of service from everyone, not just,
100%.
specialty providers that you have to pay extra for. It's
Right, because
ridiculous.
who can afford to pay extra for those people who probably already have fairly decent coverage?
Exactly.
We say, insurance has often been for the healthy and wealthy. So before the ACA, you could be denied coverage if you had a pre-existing condition. So you got insured if you were healthy, and then the good insurance goes to those who are wealthy. And there's good, actually, pros and cons to that, because there's other stuff we don't have time for today around being overrated. But yeah, so Forward,
It's a big hairy ball of wax, this problem. It's
it
huge.
really
Yeah.
is. It really is like a cat fur ball. It needs to get coughed up.
Is that like, I'm thinking the tech companies, they looked into it saying, yeah, we can solve that problem. It shouldn't be a problem at all. And then they started getting into it and they were digging and digging and digging and digging and eventually said, oh my God, this is too hard. I'm gone. It's like,
So
seriously?
when I talk to startups and innovators, I mean, I ask them this question very seriously. Is your success metric a press release that you've been chosen, or is
Yeah.
it actually making an impact? Because
Hmm.
they're two really different things. And the slog is no joke. If you
Yeah.
want the press release, that's great. If that press release is dependent on an insurance plan actually doing something, giving you data, giving you access, implementing your solution on a large scale, be ready
Hmm.
for a very difficult, very stakeholder heavy stakeholder engagement program, and be ready for lots of nodding heads about the solution. But you're going to have to really, really work to get that carrier to allocate resources to implement this idea. Now, you might
Yeah.
just want the press release. You might want the
Yeah.
press release that says, I'm doing business with the largest insurer in the country. If that's what you want, that's great. And I'll give you an example. There's back to South Africa. South Africa, Discovery Health tried to make a play in the US, and they created a company called the Vitality Group. And I worked there for a little while, and I'm not going to say anything that's not public, but they'd had a joint venture with Humana.
Hmm.
Huge win. The joint venture was, had hooks in it that each partner had to perform certain duties so that
Hmm.
for it to be effective. And they could not. It was a great idea. Let's give points to people for doing healthy activities,
That
and
sounds
they can
great.
use those
There's
points.
some companies that are doing that right now, right? Like
Yeah, they do it all the
Rally and
time.
stuff like that.
Yeah, it just doesn't make a difference.
No.
people are not getting healthier. But, the problem
But they're
wasn't
going
that
for points.
they're going for points, but they don't always use them.
No.
Anyway, but the point was that relationship disbanded, and it wasn't because Vitality wasn't doing their thing, because the startup has all the motivation in the world. It was because I couldn't live up to their end of the deal and actually get the penetration of the product into their sales cycle and into their client population, et cetera. So
right.
Boy, did I just outline another problem? I think I feel like
you did.
full of problems and no solutions. But there are solutions.
But the problem is that we're all looking at the low hanging fruit, and this is really, really high hanging fruit that needs to be picked. But we have to have the, I don't know, the strength and the willingness to just push through and have to go through the slog to get a solution here. Otherwise, it's just going to stay the way it is.
And for your tech companies, you have to invest in the soft skills, because you really can have the best AI solution. There is nothing that is saying that we're picking the smartest vendors out there either in healthcare. We're picking the vendors who have the relationships, who can make that happen. And then, we're not really seeing full scale adoption and distribution throughout the market, which is the other problem. And that's, again, I love integrated delivery networks. I'll say that. The delivery network that has a health plan, that's interesting. Sharp Health Plan, San Diego. Very interesting. They do really good work. And, when you have that close integration between the carrier and the provider system, that's interesting.
But that's only in San Diego?
Well, no, we have them there. Well, Kaiser's the biggest one, but they're a close network. We do have others in the state of California, and then we've got good examples of good care, Mayo, Cleveland Clinic, Geisinger. It's just that we don't have control of cost and spending necessarily.
Yeah. Well, I know that some of these, like we're with Stanford, and they're great, and they share data and all that good stuff. And it seems like they're using tech properly as well, but it still seems like they're only solving part of the problem. There's lots of other stuff out there that could be fixed.
Yes. And this is a great example of, I want you to change it, but don't change my Stanford. Right? So we came in and said, we're going to shake it all up. The people who are like, I love my Stanford, don't touch my stuff. But we need we need.
No, I wouldn't mind going for something better if there's something better out there. But it's like we've bounced around from plan to plan to plan to plan, and now we're here, and it's like, oh, please don't change my plan.
Don't change my stuff. Like, I wanted to stay the same, but fix everything else.
Yeah, that's right. Everyone else has a problem, not me.
Yeah. But
all right, so
I don't know. Are we out of time? I don't even know.
No, we got to talk about let's talk about the future. So it's time to think like a futurist. 10 years out, 2033. Do you think we're going to actually have some real change by then, or do you think it's going to be status quo for the next 10 years?
I am a future state thinker, and I'm not done driving change. So I'm going to say it's going to change. And I am particularly interested in working in really meaningful ways on projects. So getting beyond the incremental improvement to the performance engine and really working on that large scale change. And maybe it is, and I think you're right, the size of the country is huge. So we can have geographic pockets, and maybe it's a couple of states, 3 or 4 states that get together and say, we are all going to adopt these quality metrics, and we're going to refresh them every 5 years. And so once we receive and see improvement in a certain area, because otherwise we're just poking the balloon. Once we see improvement let's say it's every 5 years, because it takes 5 years to show any kind of improvement, we'll update them. Right. So, yeah, I absolutely think that we have to do something and change something. And I don't think Americans are going to stand for this to keep going. I mean, we're just seeing a bigger and bigger gap between lower and higher and upper class, and it's just getting really difficult to be successful. in the United
What
States.
do you see any states that are a little further along? I mean, is California further along? We usually are, but are they? Is California any further along in that kind of metric tracking?
Absolutely. So California is still has a large HMO coverage state,
Hmm.
but we
Yeah, Kaiser's everywhere.
Kaiser is everywhere, and Kaiser is good. Kaiser is really good from an outcomes perspective. So some people hate it, and I understand they want choice, and that's fine. But we really should be looking at models that are integrated, like Kaiser can
Hmm.
have a network model, successful network model Kaiser, where the doctors aren't employees, but it's actually networks. I think you can, but you have to really be organized.
Mm.
Somehow there are, at least 8 big plans that have huge membership in California. There's some state plans, and then there's some national plans that have a presence, right? You really have to organize around a focused future state.
Mm.
In the future, we all agree we're going to invest in this type of change. It's got to be one or two things. It can't be 30,
Yeah. Yeah.
so 3 quality metrics and, a payment model.
Hmm.
And there's a lot of effort. There's really good work out there. There's a not-for-profit called APN that has put out multiple models of payment and a maturity model for that payment progression. So they
Interesting.
go from fee for service to this model of risk distribution. Maybe there's, it starts with upside risk only. You're
Hmm.
not going to lose money if you do poorly, but you'll gain money if you do well. To, all right, you're going to actually lose money and gain money. It can go either way. That's,
Yeah.
risk to more value-based, that it's really a larger scale. It's not just by a provider, it's by a system.
Right.
Like tell in this population, everybody's rising. The tides are bringing all the boats up.
Hmm.
Not just, this one this one health plan or this one provider is doing well. It's that people as a whole, because right now we pay for, if you go to, let's say we have a capitation relationship with Stanford as a health plan, then we're just measuring Stanford. Well, that's great if you stick within Stanford, but if you go someplace else for other parts of your care, it's not included in the capitation, right?
Yeah,
You need
exactly.
capitation to be whole systems. Anyway, it's kind of nerdy, I know, but I love it.
But it sounds to me that what you're saying is that we do really need sort of like a top-down approach, because if we don't get that, then we're not really, I
We need
mean,
some market organization.
nothing's going to organically grow.
Yeah, we need some market organization, but I don't want all the antitrust people to come, try to find me in Denver and, hunt me down. I'm not talking about collusion. I'm just talking about organized effort at a future state in which, people are living longer and healthier, happier lives. The cost is, this is not my idea, it's called the triple aim. So the triple aim is, people are living better lives, longer, healthier lives. The cost burden is reduced, maybe even reversed.
Hmm.
And the patient experience is better. So we're making significant effort on things like patient experiences getting better, but we're not making inroads on large scale quality care getting better, populations getting healthier, and we're definitely not doing great on cost.
Yeah. And my concern is that we have to depoliticize the environment, because it seems our environment is so politicized that no matter whatever you present is going to be, oh, it's this or that, there's this or that. It's like, why can't we, if we could just, can there not be a third way that doesn't go in either direction, that
Yeah.
just looks for better patient outcomes? I mean, I think everybody wants, there must be some things that everybody wants. You can't just say, it's not always XY. There are common things that all human beings look for. And, living longer and being healthier, I think, are probably probably as apolitical as you can think of. But if we can politicize that, and then, I mean, how do we depoliticize it?
So it's, people will agree mostly on that. It's the manner, it's the road to get there. It's the path
Right.
that they are very sort of stubborn about.
Mm-hmm.
I implemented Covered California, me and my company. My specific job in that role was to launch 13 health plans. And a bunch of different dental plans. And then I had staff that were doing other regulations and things. I can't tell you, like, even just posting on my Facebook page, that's what I was working on. I would have, close friends and relatives who were like, what you're working on, that it's ruining people's lives. And I'm like,
Oh my
it's not
God.
ruining people's lives. Like, actually people are getting coverage. So, the what do they call it? When you're making up the facts,
What,
alternative
fake news?
fake news, yeah,
Alternative
fake
facts?
news, the fake news. And so I think it's going to take, a smart Canadian like you, Chris, to help depoliticize healthcare and figure out how we can get people to start working towards, better health outcomes, for all people, not just for Democrats or Republicans or
Yeah.
independents. Like, everybody should have, better cancer care. Everybody should have, better diabetes care.
Yeah.
So, yeah. But
Like I said,
think,
it's almost like we need a apolitical revolution, saying, okay, here's a bunch of stuff that shouldn't be politicized. Let's all work on it together, and then you can play with the other stuff at the margins. But
and you need
this,
you need private and public sector organization around those things.
yeah,
And there are models out there that could be effective. Stakeholder influence.
mm-hmm.
You really got to address the cultural issues, and we have to address the cultural issues with carrots and sticks, right? It's not I hate to say it, but who knew it was so complicated? All of us. All of us knew it was really complicated. So
That's right. But we've got to really toughen ourselves up and say this is a fight worth fighting, and we need to win it.
Because people are dying.
Yeah.
And they're not living great lives.
Yeah.
We're not improving generations of life expectancy.
Yeah. And that is really that's the goal. If we just have to focus on that.
Yeah. We're paying a hell of a lot of money to do a really crappy job.
Yeah. Normally we'd fire ourselves for that, but
absolutely.
I wish we could. Well, thanks so much. This has been great. If somebody wants to get in touch with you, what's the best way?
So my name is leesa.tori at brightsidesolutions.com. And www.brightsidesolutions.com is my website. And yeah, I love talking about this stuff. So if anybody does want to get a hold of me, please do. I'm not right on everything, and I'm very curious about other people's, perspectives. But I also think that we have to choose something.
Oh yeah, absolutely. I'm in 100% in agreement with that. Thank you so much. It's been great.
All right, Chris, have a great rest of your week. Take care.
You too. Bye-bye.
All right, bye.